In this module, we'll be seeing the components of cardiovascular system examination. In the previous few classes, we saw the components of respiratory system examination, which was divided into inspection, palpation, percussion, and auscultation. In cardiovascular system, actually, the percussion part is not expected, right? So we just have inspection, palpation, and auscultation. So before we go into the components of inspection of cardiovascular system, let me just explain you the main precordial regions. Now, in general, ideally, you need to just call the region as apex. So this is the apex. Left lower sternal edge, left second space, right second space, left precordial region, epigastric region, suprasternal region, and to some extent the right lower parasternal region. So this is how we divide it. So let me just repeat. So you have the left, the apex, which is the location where we assess for the mitral valve. So sometimes this we call it as a apex and also the auscultatory area for the mitral valve. Then the left lower sternal edge, which classical teaching calls it as tricuspid region. Left second space, which we call it as a pulmonary region. Right second space, we call it as the aortic region. And then the left parasternal region, right parasternal region, epigastric region, and suprasternal region. So at a postgraduate level, we expect you to tell that, not mentioning the pulmonary or aortic. You need to tell the space and tell. The reason is very simple. In a diseased heart, we cannot go by assumption. So for a PG level, only the region should be told. Whereas for undergraduate level, you can just remember it as a different regions. Okay, so core regions, what you will really require as a UG will be the apex or the mitral valve region or the mitral region. Then you have the tricuspid region, which is the left lower sternal edge, the pulmonary region, pulmonary area, which is the left second space close to the sternum, aortic region, which is the right second space close to the sternum. In addition to that, you have the left third space, which you call as a Erb's area, which is also called the second aortic region. So these are the primary regions which you should remember as far as cardiovascular system is concerned. Now in cardiovascular system, the main thing you will be looking at will be the movement of the precordium. So movement can be just a pulsation which is visible, or it can be movement of the chest wall itself, which we call it as a heave. So one point you need to understand here is that if you see that the inner part or the medial part elliptical rings are the actual location of the valves. So this is the location of the mitral valve, which is located behind the sternum. Location of the tricuspid valve, again located behind the sternum. Aortic valve and the pulmonary valve. But the place where we study these valves are distant apart. So you can see that the mitral valve is studied at the apex. Tricuspidal valve is located actually going towards the jet, but here you have the liver which is overlapping. So what we do is that jet does not come in this direction alone. Always, more commonly, this arrow mark is applicable when there is a right ventricular hypertrophy. So in healthy individual, it will be directed like this. So you use the left lower sternal edge for the tricuspid region. And for the aortic, the jet is like this. And for the pulmonary, jet is. That's why you can see that the regions are located at a distance away from the valves. So that is the rationale why we are not exactly auscultating on the valves, but looking at the jet which usually falls at a distant place. Now you may ask that in regurgitant lesion, the question automatically which will come to your mind is in regurgitant lesion, the jet is in the opposite direction, isn't it? So why is that you are still following the region? So your question will be, during diastole, blood will be flowing this way. Whereas when in systole, blood will be going in the opposite direction. So when there is a mitral regurgitation, they will be leaking back into the left atrium during systole. So how can you study at the apex? The reason is because when there is a regurgitation, you will develop a lot of vibrations at the level of the valve. See, these vibrations will travel through the chordae tendineae and through the muscles, and it will be, again, it will have a backward audibility of the turbulence will be heard, because that's the only way the sound can be transmitted, because the thick myocardium does not permit. So therefore it should follow the direction of the jet, and therefore these vibration will automatically fall back, because we know that all these structures, the chordae tendineae, the papillary muscles, are attached back to the wall of the heart. Therefore you auscultate here. So that is the rationale. Again, in aortic regurgitation, okay, stenosis, it goes like this, agreed. But in regurgitation, it comes behind, isn't it? So again, the regurgitation, it will be heard. The jet will be directed like this. So it will be appreciated in the left lower sternal. So this is the basic rationale of why the areas are at a distance from the auscultatory areas. So this regions you need to really look at, because in the inspection, this is what you will assess. Anyway, I'll go to the list and then I'll come back to the areas. So we'll come back to these areas on what has to be seen after I make you understand the. So this is the list. Many of this as already I've told along with the respiratory system, so I'm not going to repeat it. So the first four things is the same: the shape of the chest, the symmetry of the chest, sternal deformity, which is excavatum, which is depression, carinatum, which is projection, kyphosis, and scoliosis. So what I put in bracket is what you should ideally do. Or in other words, if the assessor sees, this is what they will assess. So when you see the shape of the chest, are you seeing it through the shoulder? Already I told it under respiratory system examination. Symmetry, you have to see in the front and the back. Sternal deformity, ideally you have to see from the foot end with the patient lying down. Kyphoscoliosis, you will see from the back and laterally to some extent. Now, compared to respiratory system, here these can actually directly interfere with the finding. So let's see how. Shape of the chest can affect the apical impulse. For example, if the shape of the chest is, if the AP diameter is increased, you may not be able to see the apical impulse, right? When symmetry is grossly affected, for example, when there is a asymmetry of the chest, either due to skeletal deformity or due to underlying lung problem, what will happen? The position of the heart may also change, isn't it? So therefore, you may not be able to exactly assess the apical impulse in the proper site. When there is an excavator, so when the sternum depresses inside, that will compress the heart which is behind it, and it may displace the apical impulse. So apical impulse can be again displaced laterally, right? And carinatum, when sternum comes forward, you may not be able to appreciate the apical impulse. Apical impulse may be non-visible. Kyphoscoliosis again can have an effect in the form kyphosis will make the apex difficult to appreciate, because the heart comes posteriorly when there is a forward bending. Lateral bending can shift the apex. So all this can influence the examination of the heart. So That's why these things should be seen first. And tracheal position adds to the assessment of the mediastinal position. Now coming to the main part. Now coming to the main part. So this is what you need to really assess there. So coming to the main part of the inspection, you need to look at the apical impulse. So how you should eliminate, we'll be seeing it in the subsequent slides. How should I see an apical impulse? And other area where you need to look for the cardiac movement is the epigastric region, which I already told in the earlier slide. Left and right parasternal region, suprasternal region. So this has to be eliminated properly, and let's see how you need to do that. And in cardiovascular system, more important is the scars, which could indicate previous cardiac surgery. Others are not that much relevant in cardiovascular system. Now coming to the technique. So first is apical impulse. Apical impulse is defined as the lowermost and the outermost part of the cardiac impulse, which is seen. Okay, this is a classical description of apical impulse. When you palpate the same apical impulse, you will call it as lowermost and outermost part of the cardiac impulse, which is felt, which is called apex beat. So, but this is all just for the sake of definition. But remember, this is the lowermost and the outermost part of the cardiac impulse, which is seen. So you are able to see a patient who is the supine position with the precardium exposed. You can clearly see that this is the angle of Louis. So this will be the left second space, third space, fourth space, and fifth space. So normally you will see the apical impulse half an inch medial to the midclavicular line. So midclavicular line will be crossing somewhere here. Okay, crossing somewhere here. So you will see the apex somewhere here, right? I've drawn the midclavicular line a little bit more medially. So midclavicular line will come somewhere here. It will cross this part. So about half an inch medial. That is, you can just remember medial to the midclavicular line. That inch part is not that precise in most of the individuals. Now this is the expected area where you look for the apical impulse. So you need to eliminate it. Remember, in cardiology, that elimination is very important. If you try to appreciate the pulsation, because it is a perpendicular movement from the plane of the chest, isn't it? So if this is the plane of the chest, so the movement is perpendicular to this. So only when you eliminate it tangentially, you will hit the light like this, cutting the, so in this direction if you hit, or you can also hit it in laterally, this direction. Both are okay. So some literature even specifically ask you to hit from lateral to medial, because you can see the lateralmost part, because I told you that it is the down lowermost and outermost part of the cardiac impulse. So this tangential elimination is important. So you will eliminate tangentially and see if you are able to see an apical impulse. First you will hit it at the place where you expect it in the fifth space. Then you move down and move up and see if you are able to visualize the apical impulse. So when you visualize the position of the apical impulse, ideally the patient is in the supine position or semi-recumbent. Semi-recumbent means just maybe 20 degree or 30 degrees slightly elevated, you will visualize. Now, there are many reasons why the apical impulse may not be seen even in a healthy individual. We'll take it up in the separate discussion in subsequent classes. Now, after looking at the apex, you need to study the parasternal region. So here you need to hit the torch tangentially. Okay, so you will hit like this. You will hit at the parasternal. This is the area where you will eliminate. So you will hit in the parasternal region, and you will see if there is any pulsation in the left lower sternal edge or the all over the left parasternal region, you will eliminate. Okay, so where do you expect the pulsation? You may expect the pulsation somewhere here, the lower part, or you may get it here, which is the pulmonary region. So when you eliminate the pulsation, do it both in supine as well as sitting. Though conventional teaching tells that you examine in sitting and leaning forward for the upper left parasternal and supine in the lower parasternal, I would recommend to study both the areas, that is the lower parasternal and the upper parasternal, both in supine as well as in the sitting position, because the structure causing the pulsation may go behind the rib and you may not pick up in either of the positions. So first look supine, then make the patient sit and see. So there are various reasons for the parasternal pulsation, but you need to see if there is a parasternal pulsation there. Next, what you will do, you look at the right parasternal pulsation. Right parasternal, the primary area of interest is the right second space, or the place where the aortic jet comes. And in addition, you may see the right parasternal region. In gross right ventricular hypertrophy, you may see that, but the primary area is this. Then what you will see, you look at the epigastric pulsation and also the suprasternal pulsation. These are the major areas you will look for the pulsation in the heart. So you will see the apex, you will see the left lower sternal edge, entire left parasternal region, right second intercostal space, the medial part, right parasternal region, and the epigastric region and the suprasternal region. Sometimes you will see a visible lift of the parasternal. Okay, visible lift. So you call it as left parasternal pulsation, or you call it as a parasternal heave. Okay, you call it as a parasternal heave. We call it as a visible parasternal heave. So you call it as a visible parasternal heave. So basically, you are looking at the pulsation as well as the lift of the parasternal region. So inspection, the main objective, as I told, is to look at the location of the apical impulse. One, you look at the location of the apical impulse. One, then you will look at the movement of the precordium. So movement of the precordium, already I told you, which includes pulsation as well as parasternal heave. Okay. Now coming to palpation. So when you look at the palpation, three things you try to study in palpation. First is if you are able to feel a pulsation. That is one. Second, if you are able to feel any thrill. Thrill is nothing but the palpable equivalent of a murmur. So classically described as a sensation of purring of cat. Heave is the lift. Okay. So I've just put the parts of the hand which should be used for the same. So to localize a pulsation, when you see a pulsation which is seen, or you are trying to feel for a pulsation, you use the distal part of your palm, which is the fingers. When you are trying to feel a palpable sound, or you want to palpate a sound or a murmur called thrill, you use the distal part of the palm. And when you study the lift of the precordium, you use the base of the hand. Okay, just remember this. Anyway, we'll be touching upon in the subsequent concepts. So palpation, this is the outline. So we will palpate the trachea, which we already told. Palpating the apex beat will show the technique. The patient is in either supine or semi-recumbent position. So you will localize the site, the supine position. Then you put the patient left lateral to study the character. Character of the apex can be normal, it can be tapping, heaving, or hyperdynamic. The type of apex apical impulse will be taking it in subsequent classes. Then you will palpate the tricuspid region for palpable sound and palpable thrill, which means that you will use the distal part of the palm, palpates the pulmonary area, again distal part of the palm, Aortic area, distal part of the palm. Parasternal heave, we will use the base of the hand or the ulnar border, which I will be showing subsequently. So here the position. So when you palpate the apex, first what you do, you are counting the intercostal space, and then you will go keep just over the entire lower precordium, just below the knee. So when you keep this hand, you will feel the pulsation somewhere. Let's assume that you are able to feel a tap here, right? So if no tap is felt there, it may be really difficult to localize the apex. So you need to completely mold the hand there and see if you can feel some kind of a tap there. So once you feel a tap, what you do, you can either use your middle finger. So you will flex the middle finger and you will try to press the side. But a better method, I would say, is to use the index finger. See here in this image, they are using the index finger. So here is the middle finger, right? So keeping the index finger, pressing and see, you are able to really feel it out. Well, when you keep the hand, you feel something. So you are bringing this finger, single finger, to this point, and you are feeling if you are able to appreciate any pulsation. So that confirms the position of the apical. Now, once the position is appreciated, you put the patient left lateral. So left lateral basically brings the apex more close to the chest wall. So once it brings it more close to the chest wall, you can better appreciate two things. You can better appreciate the heart sounds, mainly the S1, and you can also appreciate any thrill if it is produced. So you put the patient in left lateral to study the apex. So the picture it is shown here. So you can even make it little bit more laterally. So you can just move your hand. Inch first you keep here, then you inch by inch you move and see if you are able to appreciate any what character you are appreciating. You should be able to check that, right? So now going to the palpation of the parasternal heave. So I told you that this is the parasternal region. So this is the left parasternal region. So in the left parasternal region, here what I am doing is that I am using the base of the palm. So I am just keeping the base of the palm in the left parasternal region and applying a slight pressure over the chest wall. So when I apply pressure over the chest wall, if I am feeling that my hand is being lifted, then that indicates that there is a parasternal heave which is present. Sometimes you will have a pulsation, but the heave may not be present. So here we are using the ulnar border is kept here. This is more preferred, I would say. So here it is easy for you. You will keep in the left parasternal region and gently press. You will give a firm press on the parasternal region and see if it is lifting the hand. So if it is lifting the hand, then it indicates that there is a parasternal heave. There is a grading of the parasternal heave which is not standardized, so I am not going into that. So palpation, basically you look at few things. So you palpate the apex beat for two things: position and or localization, position and character. Then you palpate the tricuspid region, pulmonary region, aortic region. Now here, tricuspid region, you will palpate just in a supine position. In pulmonary and aortic area, you need to make the patient lean forward. The reason is because you are trying to bring the pulmonary structure and the aortic structure, the root, more close to the chest wall. That is the principle, right? And technique for parasternal heave also I have told. So now coming to auscultation. Percussion is not any longer practiced in cardiac examination. So main thing you need to remember about the part of the stethoscope is the diaphragm and the bell. Remaining structure, there should not be any leak in the tubing, and this should snugly fit your ear, right? Initial days your ear may pain little bit, but when you auscultate, don't try to separate the earpiece and auscultate. Some students have the habit of doing that, trying to separate it little bit. So try to buy stethoscope which has something like a cushion. If it's a plastic, if you feel it's painful, you can just put some something like a headphones cushion there. But don't try to loosen the earpiece and auscultate. That will not help in any way. And when you keep the diaphragm, it should be kept well over the auscultatory area. The entire rim of the diaphragm should fit into the auscultatory area. Any small gap, it will cause interference from the air which is coming through the space. So the rim should be well fit into the chest. Now general teaching tells that the low pitch sound, that is the mid diastolic murmur of mitral stenosis, S3 and S4 is better heard with the bell. All the others are heard with the diaphragm. But for undergraduate, it may be difficult because using the diaphragm bell is little difficult, because one is the design of the bell is not correct nowadays. It should be shallow and little wide. Nowadays the bells are too small and steep, and they are more they're not shallow, they are more steep in depth. So getting the rim seal may be difficult. So I think as a UG, you can, for all practical purpose, you please use the diaphragm for all auscultation, learn it well. Then later on you can learn the keeping the bell, because when you keep the bell, you have to just get a seal. When you keep the bell on the chest, it should be just a seal should be there on the skin. That's all. So there should not be any. So let's say this is a bell. When you keep on the skin, the seal should be there. And you should not press. You should keep it very gently. So when you press this, the skin becomes the diaphragm, and it bell becomes a diaphragm. So don't bother about the bell now. So just concentrate on the diaphragm and try to use the diaphragm properly for auscultation. Ensure that the earpiece is snugly fit into your ear. Now, what is that you will auscultate? So you will auscultate the primary areas I told is the mitral, pulmonary, aortic. To begin with, you start from the area where you appreciated a palpable sound or thrill. That's the ideal way of doing it. But some assessors will always expect you to follow one direction. That is mitral, pulmonary, aortic, and the tricuspid region. So here by mistake, pulmonary is typed twice. So mitral, pulmonary, aortic, and tricuspid, or mitral, tricuspid, aortic, and pulmonary. Clockwise or anti-clockwise direction you follow. But personally, I would recommend you to start from the area where you had an abnormal palpatory finding. Like if you had a palpable P2, you can always start from the pulmonary area. If you had a thrill in the apex, you start from the apex. If you had a thrill in the aortic area, you start from the aortic area, because thrill gives you the localization of the murmur. Because sometimes harsh murmur will be conducted all over the chest, and we may sometimes get confused on where it is actually originating. So to avoid that, you go by the finding in the palpation and inspection. So if you see a pulsation in the left second space and a palpable P2 in the left second space, you start auscultating the pulmonary. But follow what has been told by your teachers and follow that in the assessment. Personally, in a regular clinical practice, you can follow the concept which I told you. Now, each area you see if S1 and S2 is heard. Every area. For example, for UG level, I will just tell the mitral area. Mitral area, example, auscultation of mitral area, S1 and S2 heard, normal intensity, no murmur. So S1 and S2 is heard, comment on the intensity, comment on the murmur. Three things you should do. So alternatively, you can tell S1 and S2 is heard, S1 is muffled, S2 is normal intensity. There is a pansystolic murmur heard. Then you will elaborate the murmur. So that's how you, in every area you have to tell. So you have to tell auscultation of the mitral area, S1 and S2. Normal description will be auscultation of mitral area, S1 and S2 heard, S1 S2 of normal intensity, no murmur. Auscultation of the tricuspid area, S1 and S2 heard, normal intensity, both normal intensity, no murmur. When you go to the pulmonary and aortic region, concentrate more on the second sum. So you will tell it S1 and A2 in aortic region, S1 and P2 in pulmonary region. Again, you will tell whether it is normal intensity, any murmur is heard. Now, if a murmur is heard, you need to describe few things. So I'll just tell the most important things. Certain things we already know. So I think for you, for all practical purpose, I asked you to use the diaphragm or the stethoscope. So when I talk about the murmur separately in the next module, we will elaborate it. Here I just want you to understand the most important thing you need to know when you auscultate for murmur. So site we already know because we are keeping the stent there. And position of the patient I already told you. For the apex it is left lateral. Apex it is left lateral. For the tricuspid region it is left lower sternal edge patient in supine position. Aortic and pulmonary region it is sitting and leaning forward. And don't bother about the phase of respiration for you. So what you need to really look at is the timing, systolic or diastolic. Description of the murmur. When you hear a murmur, if it is systolic, it will be between S1 and S2. So you need to tell when is it starting after S1, how is the intensity all through S1 and S2? Is it the same intensity or increasing and decreasing in intensity? That is called the description. And is it conducted? Apical murmur may get conducted to the axilla. Aortic murmur may get conducted to the carotid. The left parasternal murmur will be conducted to the left lower sternal. So these three things you just remember: timing, description, and these three things you need to really understand, right? So with this in mind, I've given you an outline on the auscultatory part of the cardiovascular examination. So this gives you an outline about inspection, palpation, and auscultation of the cardiovascular system. Later on, I'll be giving more elaborate modules on specific aspects of cardiovascular examination.